Hello, my name is Dr. Sam Richardson, and this is the cardiac video for the bedside review series from Mountain View Hospital. As a reminder, these are short videos for rapid review prior to performing point-of-care ultrasound and are not a substitute for a full didactic experience. The point-of-care transthoracic cardiac ultrasound is performed with a phased array transducer. The purpose of this exam is to estimate ejection fraction, identify pericardial effusion and/or tamponade, look for signs of right ventricular strain, and evaluate for return of spontaneous circulation during cardiac arrest. When evaluating the heart, the views that are normally obtained first are the peristernal views in the long axis and short axis. These are typically obtained with the probe just to the left of the patient's sternum. Start in the second or third intercostal space and move down the chest until the heart is visible if it is not seen immediately. When your depth is set appropriately, you should be able to see the descending thoracic aorta in the far field. In the peristernal short window, it is recommended that you image at the level of the mitral valve. Next, move to the apical view. This is often most easily accomplished by moving diagonally on the chest from the peristernal short axis window until the heart is no longer on the screen, at which point the probe is laid mostly flat. You will likely need to go down further on the depth setting for this view. To determine which side is which, identify the descending thoracic aorta as well as the aortic valve. Both of these indicate the left side of the heart. It may be helpful to roll the patient to the left lateral decubitus position for this view in particular. Next, move to the subxiphoid area. We recommend that you place the index and middle fingers of your non-scanning hand against the patient's xiphoid process and then place the probe immediately caudal to your fingers, laying it as flat as possible. Placing the probe firmly into the patient's xiphoid process is often uncomfortable, as well as producing substandard images. It may be helpful to have the patient do an inspiratory breath hold to bring the heart further down into view. It may also be helpful to move the probe to the patient's right to better use the liver as a sonographic window. The final view is the inferior vena cava, which may be identified by turning the probe 90 degrees clockwise while in the subxiphoid view. We would strongly recommend that the less experienced ultrasound users identify both the aorta and the IVC every time this exam is performed, as the aorta is often mistaken for the IVC. When performing this ultrasound on female patients, you will need to adjust your probe movements to account for breast tissue and patient attire. Try to avoid exposing the patient any more than is absolutely necessary to obtain high-quality images.